its onset begins early in childhood, and it has been recognized that the incidence is getting more and more reported. 1 in 88 in USA, which is now increased by 15%, and the most recent statistics from the MMWR shows 1 is to 59 children in the US. In UK, 2% of the boys have an autism spectrum disorder, and which is therefore truly catastrophic. We don't know what is the incidence and the level in Tanzania or in Africa in general, but it has become increasingly recognized in Tanzania. And therefore, we are considering whether it is a silent epidemic or is actually increased awareness. If it was increased awareness, then we would find even adolescents and bigger people being now diagnosed with autism now that we have increased awareness. But I think there is increased incidence, but it remains to be seen what next. Autism is a well-recognized condition. Way back in 1940s, Leo Kanner described 11 children with these features, in which he described 2 essential features. Autism means the children were self-independent, they did not want anybody around them, and resistance to change. They did not want any change. And he thought they might be congenital in nature, and they were related to developmental issues. He further described the pathognomic finding, saying that child is unable to relate themselves in situations right from the beginning of their life. There is extreme autistic loneliness or aloneness. They disregard, they shut themselves, they are all alone, they don't want anybody around. But now I'm just going to change a little focus here and say, there is a norm in psychology and in normal cultural behavior. There is a norm saying when a child grows, you teach him, you greet your elder, you do salam, shikamo, whatever, right? That is the norm, which is a taught norm, a norm which has been socially prescribed by us. But who says that that is norm? The autistic child has got his own right. For the autistic child, that norm for that child, his own life has his own right to not greet you and should not be labeled or judged. I will continue more on that. So common development disorders are autism, Asperger's disease, pervasive development disorders not otherwise specified, Rett syndrome, and childhood degenerative disorders. Whereas for autism and Rett syndrome and childhood degenerative disorder, the clinical characteristics are very clear. For example, in Rett syndrome, it is a younger girl who is keeping on playing her fingers right in front of her face and has slight deviations of the hands and is probably a little mentally retarded as well. Whereas for childhood degenerative disorders, there are many conditions which can be related to metabolic disorders or other development disorders. Asperger's syndrome is actually probably a spectrum of the autism. This is autism in its kind of normal, but they have a more of vocalization and speech thing. Coming to Asperger's syndrome, there is a story which was recently published in New York Times about Asperger. And they say that maybe we should not use the word Asperger because he was a Nazi child murderer with eugenics and describe this name. And probably he was a representative of the Nazi, but irrespective of what, we need to keep this name, whether you want to remember the memory or not, but he's the one who described it. So we should continue remembering this name in either way. As you heard, autism spectrum disorder, it is a spectrum. And sometimes in a very joking way, in UK or in other countries, I have heard people saying, whenever they find somebody is little introvert or little not wanting to mix with others, they will say, I think he's a spectrum. They use it very loosely, that is not right, but then it is a spectrum. So we might be in the spectrum and we not need to recognize ourselves. But compulsive obsessive behavior should not be confused with autism. The symptoms, the severity is wide. It can be almost with a normal mainstream or completely debilitating with handicaps. And the early signs indicate that if a child is not babbling at around 1 year, there are no single words at 16 months or about 1.5 years, so dada, mama, tata is not developed yet. There are no response to calling his name or her name. His is more likely than her because it's 7 to 8 times more likely in boys than girls. And then there are loss of language skills and social skills. Poor eye contact, there is no eye contact. And excessive lining up of toys or objects and repeated, there's no smiling or social behavior and repeated activities. Later indicators indicate inability to make friends with peers, impaired ability to initiate or sustain conversations, absence or impairment of imaginative play, stereotype repetitive movements, restrictive patterns of interest, and preoccupation with certain objects and subjects, and inflexible adherence to specific schedules. So if you gave him a toy, this is what he would do. He'd first start smelling it, maybe even lick it, and then start looking at it. If this was a car, instead of playing it as a car, he would just concentrate on the wheels of the car, and because they love repetitive movements, he would just be moving the wheel for hours and hours and hours without tiring. So sometimes in a lighter tone, I say, but don't we have tons and tons of adolescents and youths who are autistic because we have this gadget? They don't have eye contact. They don't have eye contact. They don't have communication. They are constantly fidgeting something with their interest, and there are no social relationship with the surrounding. So maybe be careful. Don't be too much engaged into this, otherwise we will label you at the spectrum. That was on the lighter tone. Coming to in the environment, the autism spectrum disorder is not well recognized in the environment. While I was distributing the invitation cards to quite a number of you in the field here, in the house, and you can say that this is not true, you are just putting on the words in our mouths. They said, but what is autism? Is it mental retardation? Is this those children who don't want to eat? And I said, you come to the lecture and you will hear what I'm going to say. It is actually not all those things which we said. But there is also another aspect, that those who have children with autism, they are very vulnerable, the children and the parents, because they would look for anything and everything to help their children. And they would therefore go into treatment modalities which can be very dangerous. And for example, in South Africa, I haven't quoted this in the slide, but one of the study in South Africa, in one of the reviews, in a newspaper article, there was a group of people who were actually in the church, and no negative connotation about the church, but about that person who used the platform of the church to use the wrong medications for the children. He invited these people, parents who had children with autism, and said, I have a cure for you. And the cure was a mixture of all kinds of concoctions and anything and everything there inside, garlic and ginger and whatever you may think of. It was all added, and these children were given. And number of children from that area were then hospitalized, moribund, sick, almost dying. So be careful not to be taken up with this interest. Like, of course you need some treatment for your child. You're not doing anything bad. But then you need to be very careful, because there is no cure as we speak now of autism spectrum disorder. But behavioral interventions which are specifically designed to remedy these symptoms will bring out a substantial change. And interventions include psychosocial treatment, which is different from age. Treat the seizures, which are comorbidity, the depression and behavioral problems, and continue in a supportive environment. Family counseling is very important. in this aspect, and I've highlighted in this slide. These slides will be seen in your booklet which you are given, and for those who do not have the booklet, it will be uploaded in the website for you to access. So family counseling for parents and siblings are very important, and we will come to it when we do the interventions. So I talk about the treatment. So there are several tools to diagnose these children. If we find a child is not talking at 2 years, has got unusual behavior, so how do you diagnose? What are the tools? So there are certain tools, the questionnaires, where you have to fill in. The most common one, or the most widely used for children under 36 months, is the modified childhood autism scoring sheet. And this one helps for the toddlers to identify. There will be 7 items which are bolded, and if you have even 4 items out of 7 which are positive in these terms, then it is highly likely that this child has autism and should be taken to a specialist, a psychologist or a specialist, who will then further confirm. Then there is the childhood autism rating scale, in which you can now rate whether this child is a high function or a low function. Means he has a very low spectrum in the end of becoming mainstream, or in the spectrum of becoming very disabled. And then there is the SRS tool and the other tools mentioned here. But the most widely used now in our practice is the DSM-5. The American Academy of Pediatrics has suggested that the M-chart be used for every child between 18 and 24 months in order to identify earlier children who might have autism. So what are the problems globally? Globally, we have problems of misconception, stigma, cultural norms and beliefs, vaccine controversy, sibling care, marital disharmony, parental exhaustion, and the perspective of the autistic child himself. Sometimes I think we need to shift the paradigm. The doctors are always the prescribers. The doctors are always the ones who tell parents and teachers what to do. Your child has convulsions, the child should not go swimming, he should not be cycling alone, he should not do this, he should not do this, be careful, he should not go deep sea diving and things because he has convulsions and is anti-convulsant, blah, blah, blah. It all comes from the doctors to the caretakers and the educators. I think we need to shift the paradigm. The teachers should tell us that this child is undergoing such and such issues. And I think this is a better way to approach this child, and not a prescription or a magic bullet which is given by doctors. So we need to shift the paradigm to see how we can empower these teachers, and more so the parents themselves. Causes and etiology, we don't know actually, no specific cause recognized yet. And I'll just go quickly through this because I will take an advantage of passing through, because some of you might want to ask me that questions. So I'll save time from this presentation. Insecticides, vitamin D deficiency in pregnancy, infections, drugs during pregnancy, genetics, environmental toxins, developmental disorders, brain dysfunction, low APGAR scores requiring resuscitation, premature babies, micronutrient deficiencies, and so on and so forth. But no specific cause has been recognized yet. There is some inclination towards genetics, but it is still being investigated. Newly identified diagnostic tools are EEG and genetic mapping. These are like really new kind of discoveries. Only in May 2018, while I was preparing this lecture with in collaboration with the Harvard School of Public Health, when I was there doing this topic, this is where I found some more recent findings of. So it's very interesting to see how EEG, and this is what the EEG pattern. This is the whole pattern here, the graphs. As we know, for those who know about the EEG is like everywhere. Like when you see the EEG, multiple sheets, like 25 pages with all the waves going up and down. For many of us, we don't know what it is. But the researchers here have consolidated all those things and made into curves in order to be easily interpretable. And they have seen that some sample entrophies, particularly on the temporal lobe, on T7 region, and some kind of dip there can identify which child can develop autism in the near future. So it's very interesting. It is not widely used. It is still under research, but some good things to look into. The algorithms which predicted the clinical diagnosis in this one had a very high positive predictive value in the EEG thing. Exploring autism from genetics, and this slide has been adapted from Science by Sukanya Charuchandra from Boston Children's Hospital, and it shows here that there is some elements here showing whether it is in lab experiments or humans that there is a genetic component, and further research is going on this one. The genetic component is found to be in segment, for those who are in genetics, KCTD13 is one of the 29 genes located on chromosome 16. So MED students, if I say possibly which chromosome is involved in autism, you have the answer. And exozyme is now being researched for repairing this chromosome defect, but it's still under research. And these are some things which indicate that there might be a genetic component. Tuberous sclerosis complex, the hamartoma tumor syndrome, the 16p deletion, the fragile X chromosome, Rett syndrome, and other syndromes, the Phelan-McDermid syndrome. This is a complex neurological disorder. They are involved with some of those major markers, including IGF-1, insulin-like growth factor 1, and others, which might be indicating that there is a genetic mapping there. In Africa, there are only about 10 papers described from Africa. Most of it is from South Africa and Nigeria, and I don't think South Africa is in Africa because it's too much developed. Maybe it is not in South Africa, in Africa. But there is Nigeria, most of the papers, and one from Tanzania. But the whole picture of these 10 papers from Africa describe an elderly 9, 10, 12-year-old boy with increased proportion of non-verbal cases, possible at an infectious etiology like cerebral malaria or meningitis in the background, has convulsions, and lack of, most of the time, has been misdiagnosed by the healthcare worker, including the physicians, and attributed to a spiritual cause, and they do not have any services and do not have a proper diagnosis because of lack of validated tools. And this is papers from France and Charles Newton, who is my co-supervisor for the student we are supervising for the PhD. Reports from other African countries, similar findings, although Lotter from Nigeria had described this almost 40 years ago, but not many people took it to see whether we do have the same problem in our countries. There is very little being done to these children globally, although in the UK and the US, in Boston, for example, there are 11 centers for caring for children with autism. Only in Boston itself in the United States. So you can see that the mismatch or what we need to do about autism. So I was involved with autism because I keep on seeing these children in my clinic every time and I have nothing to do. And I'm only scratching my head or as a token asking them to go and see a speech therapist or a psychologist, which is very difficult to find and very hard to locate because they are not in any institutionalized area where you can get this care. And most of the time, the mothers and the parents have lack of knowledge, and the care workers. Some of them are brought that this child is deaf, or we removed earwax, but he's still not hearing, and has a hearing aid, but the child is not deaf. So there are a lot of other things which I saw in my clinic, in my practice over the many years. I thought there is something we must do about these children. And therefore, when I looked for the tools, I came across several things, including an organization called Autism Connects in Africa, through which, with Kerry and others, we were able to identify the various tools and we will see what we have done about this. So the situation in Tanzania, what is known and what are the facilities existing? It's an appalling situation. It is a very sad situation. These children deserve more than what we can give them. It has been reported in early 90s by, if some of you might be remembering, Martha Collins, the psychiatrist or psychologist in our Department of Psychiatry. I think, Sylvia, you must be remembering. She was one of the founder members of Parents of Children with Epilepsy in Tanzania, POSET. And although I was not having a child with epilepsy, I was one of the active members there. And she went to Muhimbili and did research using a tool. Fortunately or unfortunately, this was a PhD student from Ompako organization, and was actually testing the tool of autism, ADIR. They had only seen about 14 children, of which almost 8 of them had comorbidities. This was the only described autism paper in the country. So what I did was we had interviews, we had searched, I looked into search tools, literature search, contacted Ministry of Health and Social Welfare, at that time that was the name, Ministry of Education and Vocational Training, various schools, facilities, MNH facility, pediatricians in private hospitals, and I did a qualitative and semi-quantitative analysis of what I found. And in 2013 data, there were only 8 public schools which were registered by Ministry of Education, which actually catered for children with special needs. The prevalence in these centers, in those centers, particularly in North Africa, was 437 children. And this was probably a gross estimate because my study was only focused on northern Tanzania. Information from other areas was not readily available, and the only public facilities which were existing were in Dar es Salaam, at Msimbazi Mseto, at Mbuyuni, and at Kinondoni. There's another school there. And information from private sectors showed that there is a huge cost and we are very donor dependent. The most underlying important problem was lack of trained and committed human resource. So from these several schools, what was main outcome there was they had no capacity to take care of these children. Although Autism Connects Africa has trained about 2,700 until so far, health workers and psychologists and public health people, including parents, about how to empower themselves to treat or handle autism children. But these are all scattered, and there is no way where they can consolidate and put their efforts together to help children in the country. In my clinic, in 2013, I had 18 children, and by now, in my own clinic, I have over 120 children with autism spectrum disorder. One major challenge is lack of awareness of the population. And I'll give examples here. At one instance, the caretaker has been in various faith healers in vain. Stigma is a major problem. And this mother was divorced because she was very difficult. You are responsible for taking care of my child, and therefore you are the one who are responsible. As I quote Khalid Hussein, who says, like the arrow of the compass, which always points north, The accusing finger of the men always points to the woman. It is still a major problem. In my cases, we have found many, not many, but number of women who have been divorced and they're staying separately. Although, when you interview both of them separately, they say, I don't know what is going on between us, but I think this child is a problem. The child is not a problem. You are a problem. Understand him and take him. And take him together and be there for him. Don't say the child is a problem. There was a center called the World Federation Center for Autism. This center has now been taken away by the Al-Muntazir Special Education Needs Center. And at that time, when I did the survey, there were about 28 children ranging from 4 to 18 years. And there was a group of all kinds of children. We had Down syndrome there, we had cerebral palsy, all kinds of other disorders, all clumped up together with autism. There were a lot of problems in taking care of these children. And I quote Dr. Zulfikar Ganji, who is a colleague of mine, who says that at that time he thought there was like 1:166 children are born autistic, according to his review. I think at that time it was an underestimate, and if he's in the dais here, he will tell me now that this is not the case. So Autism Connects is where we did this connection. At Muhimbili National Hospital, we have autism clinic every Thursday afternoon. There is no concrete register to clearly follow these children up. These children are becoming adolescents. Some of them have become adults. They need to be put into life back. So there is still a problem. And when I went to the Ministry of Health, I'm presenting this as an academic topic, and there is no finger pointing. I will fail my duty if I don't say the right thing at the right time. Whoever is here will take this message with no malice. When I went to Ministry of Health, there is a big register of mental health, and you have several kinds of mental health initiative, like it has been, they have been identified in adults, substance abuse, manic, bipolar disorder, whatever. But for children, it is written children. And in children, there is epilepsy and others. Everything else is in others. We don't know actually. What is that others? Epilepsy and others. And I think we need to do more about these children. They are not others. They are the special, I think. So, information from these schools, as I said, we had a number of schools, and I'll go to the table directly. From the Ministry of Education and Vocational Training, it is expected that a Braille press at Uhuru Primary School will start soon, and that will be the base as a national base for special education needs. This has to be seconded by the UNICEF so that this center starts, so that we can have access for children with special needs. Interviews with 4 renowned pediatricians echoed the same feelings, that probably it is increasing and less and less is being done for them. Unfortunately, there is a lot of corporate things going on in the country. Everything is about payment, and these children cannot afford to go on and on paying for all kinds of things. There was one psychologist in Oyster Bay who used to charge $900 to do an assessment to confirm if your child had autism. My child has autism. I am going through a lot of economic hardships. To confirm that my child has autism, I have to cough out $900. That's 1.8 million, almost 2 million shillings. I can't afford. I let it go. Let me be happy with my child, whatever it is. So it is a problem. One speech therapy session costs $50. How many speech therapy sessions will you go? This is not a malaria treat and go. So go to a speech therapist once, give $50 and your child is cured. It is a continuum process. So there are problems here. So this is the table. I'm sorry, this is a little very congested, but you will find this in the slides. If in the booklet the slides are too small and you cannot read, you can access our website where it will be uploaded and you can see this better. This is the gist which I had just spoken about. So there are only 8 schools registered for autism and 155 schools throughout the country for mentally challenged children. We do not call them mentally retarded, we call them mentally challenged. There you call mentally retarded in the Department of Psychiatry, you will go out with an F. Sylvia. There are details of these schools in particularly North Tanzania. I have a whole brochure of all the resources. Whoever wants it can just shoot an email to me and I will willingly give these things. So this was what is the situation in Tanzania. And as I said, when you are just doing nothing and presented grim data about your own situation, then you are a problem. So these are a few slides. This is a recent article on how deep are your pockets in autism. The rising cost of raising a child with autism. And how they suffer and the shortage of teachers in children with autism suffer teachers shortage. Cyriacus Buguzi, I don't think he's here, but yeah, thank you very much. This is your article. 2 months ago, he quoted this and presented this paper in the Citizen. And Nyambezi Mbano, again, through Sauli Gilead, unlocking autistic children to their full potential. Another, giving children with autism a new lease of life. These are all newspaper articles which are grim. But global barriers to treatment. We have one physician for 30,000 population. I don't sound to be a politician, but only one doctor for 30,000 Tanzanians. This is sad. That's why the country is doing deliberate efforts to increase the number of doctors. But if you talk about specialists, it's 1 is to 300,000. One psychiatrist to 300,000 population. This is even much more grimmer. And if you talk about psychologists, this is 1 is to recognize qualified psychologists. 1 is to 500,000. So we still need psychologists and we need psychiatrists. There is a grand challenge going on for global mental health. And this article is highlighting this globally. So what did we do? We did something called cross-cultural approaches to autism diagnosis and assessment for the behavior intervention. With the team here mentioned, we had the 4 pieces of the pizza. One is taking the medical and developmental history, in which we adapted the intake interview. And 2 was a semi-structured, play-oriented diagnostic tool, like this. And 3rd one was identifying the spectrum, in which spectrum they were. And 4th, doing the intelligent quotient or intellectual and language assessments, including the executive functions and other domains. And these are the tools which we used. The tool by Melissa Gladstone is very well recognized by one of the visitors and a colleague here at the desk. Melissa Gladstone did this in a cohort where Per Eshorn, who is here, had his cohort of children working in the same field to develop this tool. And we have Melba Gomes from WHO, who kindly gave us the tool called Modified East African Development Tools, which we used for the Vita Beginning study. So these are the consolidated from the DSM-V5 and other things. This is the questionnaire we made, and to a very simplified tool that you just have to say yes, no in these things and tick. If all of them has to be ticked, with a yes to say this child has autism. And then we use the CARS rating. So for example, if a child rated 37.75 and had a DSM-B of 7.65, then he had a severe symptoms of autism. As an example here, we will run through this example. Category A, in this child called Bobby, who is 4 years and 4 months, in the social communication category, there was no emotional reciprocality. He did not smile, minimal eye contact, and plays alone. The parent said A1 and A2. In the repetitive stereotype behavior, there was echolalia. I was repeating the wordings. There was stereotype language in which he could actually copy whatever he heard from the TV and exactly repeat those words without any social inhibition. So there was an advertisement which was about contraception, and this 4-year-old was repeatedly just talking, repeatedly repeating the same advertisement to the embarrassment of the parents and other people around, because he was continuously talking about that, and the parent kept on punishing the child. There was a repetitive stereotype, jumping and moving. So this child, it started early in childhood and was restricting his development, so he met the criteria of ST. As compared to David, who was 8-year-old, did not have social communication problem. This child came in, he did not have speech, but immediately came in and hugged the doctor or the health worker and started making gestures to say it's shikamo, and did not have repetitive movements, because when you told him to stop, he would stop and listen to you and was able to communicate. So David did not make the criteria for autism. So when you use that sheet, you will know. As for the CARS rating, I will just go this quickly. It is a very good tool to rate these are the 16 things which are used in the CARS tool to identify this, and I'll put an example in emotion. One of the component of the CARS tool is emotion. So the emotion has got a score. You will score 1.5, 2.5, 3.5. And in that scoring, you will see if he is overtly able to socialize. Hi, hello, shake hands. Mambo, poa, ngini petano, all those things he does. Or he's in an extreme level. So then you score that child. So you can know from this whether you score 1.5, 2.5 or 3.5. And then you make a scoring sheet to say this is a high function or a low function. So Malawi tool, as I said, Dr. Nahia, you are there? Yes. We have been using this tool in our every newborn simplified measurements for longitudinal growth and development. And yes, I see Dr. Khadija, who has used this a lot in our, she's my PhD candidate who is completed in the Swiss Tropical Institute, and used this for neurodevelopment of children with helminthes. Sole helminthes are considered to be one of the elements which cause decreased neurodevelopment. And Dr. Khadija said from Ifakara Health Institute use this tool, and I'm glad you are here. I didn't see you before, sorry. This is now being used in other countries in West Africa. And the modified East African tools we used, so these are the settings. If you see in our clinic, you will find these things lying there. And here is my colleague Ashley Johnson from Brown University. So intervention approaches. So the interventional approaches, this is the Malawi development tool, really designed for our African setting. We do not have a Hoover machine or a photograph showing a snowman to say, what is this? They will not know what is a snowman, or a Hoover machine saying, father is cleaning the house. We have a broom. We have all kinds of things which the child will recognize in his or her own setting. And it's a very simple tool which requires minimal training, but commitment. And we have almost 15 trainers, trainee of trainers, whatever, here. I think I can see John here, which is a nice thing, because now we will be able to import this information and make bigger things. So in the treatment, the fundamental thing is behavioral modification. You assess what is the behavior, you reinforce the positive behavior, or de-reinforce the negative behavior. And most important is to have the parent-mediated. The kangaroo mother care. The whole concept of kangaroo mother care is to empower the mother so that she is handling the newborn baby. So she is able to take care of the baby when it is sicker and feed every time. So we want this to be a parent-mediated intervention. So various things are done to these parents, and we did this parent-mediated intervention, keeping in mind the 4 major things. First, increase mental literacy in the parents and the community, general parent training, teaching basic adaptive skills, and teaching self-help skills. So I'll just give you an example. We have a 12-item module of this kind, which we give the parents. When I do the assessment of a child with autism, when it is confirmed, then the parent asks, what's next? Then I have to sit down for hours, sometimes 2 hours, sometimes more. And I thank my wife, who keeps a check on me, that now it is already 2 hours and you haven't had your lunch yet. And it is 5:30 p.m. And then I said, you know what, I can't stop. So she says, okay, fine. So can you take a break and have food first? So these children and the parents, when you see the worry on the parents, the stories they tell you is amazing. So we give them a booklet like that, which has 12 modules. And in your booklet and in the slide, this is an example of only one module which we are doing with the parent. And here, the parent is told, number 1, in order to improve the behavior, is get the eye contact. So how can you get the eye contact? Get him something very bright and interesting. And then say, look, Karim, look here, look here. Look, this is the keys. And then when he gives you that one glance, it's worth 1,000 hours. Okay, thank you. So when he gives you that one glance, that is where the communication now starts. Sometimes I feel, and this is my personal feeling, that when you look them into the eye, then you have opened up a whole world of a marvelous, beautiful child who has everything to offer you rather than you offering him. And I think it is a very, very interesting topic. I have so much passion about autism that my family calls me that I am autistic at home. That you are just singing and talking and sleeping and eating autism. But I think when you see and interact with these children, you will understand what I am saying. And that is why it has reached to this level that I'm glad almost some of you will come out with a lot of ideas to be able to help these children. Some of you will know now that what is autism. What I'm doing, I'm making me climb up. All right, okay. So we have something called the functional analysis, behavioral assessment, the modified behavior. So we have A, B, C. I'll go quickly through this. The A is what is the antecedent behavior. B, what is the behavior? What made this behavior happen? Number 2 is what is that behavior? And number 3, after that behavior, what is the consequence of that behavior? Is he putting the switch on? Or?
Wireless microphone.
Oh, okay, for question. No, I think we will have papers.
Papers on.
Yes, thank you so much. So in this kind of assessment, we will do something called the reinforceable. If he does anything good, you do good. Now again, when I say in the psychological way of treatment, there are many institutions. There is something called the Brain Balance, the Sunrise program. In the Sunrise program, it's a very interesting way of saying how to handle this child. So for example, you will excuse me, I don't climb so rapidly the staircase, but I'll give you as an example. They said that if your child with autism is jumping and continuously jumping, you as a parent have to stand with him and jump. Then he thinks you are like. Then he will be able to give you that look, the first glance. According to the Sunrise program, they may have some things, they may not be correct, but I don't know. The Brain Balance program, the program by who is this, David Kollner, who says that maybe they don't need anything, they just need diet modification. All this halabulla and you are doing this hangama and things, maybe they don't need anything, they just need a dietary modification and so on. So if a child asks for a cookie, draw his attention. It is allowed to use extinction and time out, but it is not allowed to beat, yell and spank, hit them physically and abuse them. So I'll just go through these behavioral things quickly. So for example, in families where popcorns, andazi, ubuyu, whatever is an incentive for the child, so I'm going to make 5 boxes. If you constantly, repeatedly do this, I'll put a sticker on one box, and when you fill these 5 boxes, you get your gift, whatever goodies you are giving the child. So in the parents' intervention, we need to increase parent knowledge of autism spectrum disorder and extend the education to include behavioral strategies. And we did this as a pilot, the parent intervention, and we are still going on doing this intervention. We are grateful through COSTECH and NIMRI and MUHAS to be able to be permitted to do this in a more broader sense. And therefore, in conclusion, autism is a recognized developmental disorder. These children are not mentally retarded. These children are not wakorofi. These children are not stubborn, arrogant, miserly children. These children are beautiful children with their own world. Research on the prevalence, epidemiology, and the determinants is seriously lacking, and awareness at various levels is lacking, and there is need to raise this awareness. There are many things in the last 4 years happening. We have walks and we have walks and talks like this, but it has to be done more. We need to know, put this in the way forward. Raising awareness, maybe to include in the mental health curriculum, in service and pre-service, conduct more research on the prevalence, engage in the state-of-art research to find out possible causes. We have a beautiful genetic research lab now, and we could invite these children and their parents with autism to see if there is a specific genetic condition which is very specific to African setting, and therefore identify our children sooner. Advocacy for special education and encourage special groups. Current research, medical marijuana, people are talking about it, whether it can be used in autism. Only in February 2018, the Federal Drug Authority in the United States has given phase 1 to use medical marijuana on a very specific group of adolescents with autism. Electroconvulsive therapy, I don't know. Diuresis, antidiuretic hormone, oxytocin sprays, gluten-free diets, avoid sugar and coffee, you know. I put here IYCD and CREDI because the Infant Young Child Development Index and CREDI, Caregiver Executive Function Diagnostic Tools, these have got a mental component of 10 questions, and this can be done as early as 3 months, where you can then follow up. So those people who are doing IYCD and CREDI, who are there in the field, you should now follow up with those 10 mental questions to see whether at 3 years you can have a positive predictive value of these IYCD items. So one should take a challenge to do that. And we need community-based research and genetic mapping. These are the references which I had used for the book, but for the write-up in the book, which you have it, there are more than that, there are about 30 references. And these are the papers which I have co-authored and authored this one. So lastly, autism is not a disease. Try not to cure us. Don't cure me. Try to understand us. Asanteni sana. Thank you very much.